Hello, hello. Good morning, everyone. Good evening, wherever you are logging in from. I am so excited to get started in just about 5 minutes. I hope you all can hear me and see me okay. If so, go ahead and type in yes into the chat box. Excellent. If you are just joining me, feel free to say hello in the chat box. Also, take a little picture of your study space. If you feel comfortable, you are more than welcome to post it on your story and tag HyGuru Prep, and I will make sure to repost it. It's always so great to personally get to know you all and connect with you on social media. So I'm looking very forward to getting started in just about 5 minutes or so. Feel free to go ahead and tag at HyGuru Prep. And if you're joining on YouTube, hello and welcome. We have Fatima, Kyle, Ahmad, Priya, Mahendra, Jennifer, Neha, Martha, Danalisa. Excellent. We'll get started in just a few minutes. All right. Well, if you are just joining us, welcome. I hope you all can hear and see me okay. Go ahead and open up your chat box, say hello, where you are logging in from. Also, if you want to take a little selfie with your study space and tag me at HyGuru Prep on Instagram, I'd be very grateful. We have an international audience here. Ryan, Katie, Mahendra, Peter, amazing. This is great. I am excited to cover this topic. We'll just give it about 2 more minutes. I appreciate you all joining early. All right. See people from YouTube joining in. This is great. And just one more time, want to make sure you all can hear me and see me. Go ahead and type in yes into the chat box if that's good. Excellent. All right. So it is the top of the hour, and I want to go ahead and get started. Welcome to this very unique high yield webinar. We are going to be covering important topics surrounding patient safety, quality improvement, and systems based practice as it relates to your USMLE Step 1, Step 2 CK, or maybe you're taking an upcoming NBME. Now, before I get started, I want to let you know that this webinar today is a little bit different than my usual science-based webinars, whether I'm covering cardiology, respiratory, everything from the clerkships, OBGYN, pediatrics, internal. What we're going to be going through is a very unique set of concepts that are showing up on the USMLE Step 2 CK as well as Step 1. These are topics that you will encounter as you go and transition into residency. And I guarantee you that on exam day, you're going to get about 1 to 3 questions per block surrounding these topics. So because today's session is so unique, high yield, active recall based, I'd encourage you to take some time to write some notes as I talk, cut out any distractions, make sure that you are staying locked in for this next hour, hour and 15 minutes. And if you're watching it at another time, I would encourage you to go through these topics and pause whenever I am asking a question so you can have the greatest amount of active recall. All right. Are we ready to get started? Let's go through this. So if this is your first time watching one of my videos or attending my webinar, my name is Rahul. I'm a practicing pediatric critical care physician. And throughout the last 10 years or so, I have had an immense passion when it comes to USMLE preparation. And here is my social media handle at HyGuru Prep. Feel free to follow me on Instagram and TikTok where I'm most active. And I'm looking forward to showing you a little bit about the HyGuru philosophy as well as my courses. So I know that there are so many resources already, and I just want to spend a few moments telling you what makes HyGuru super unique. HyGuru, especially for Step 2 CK and even Step 1, is a strategic active learning approach. We focus on vignettes, thinking like the test maker, integrating different organ systems. What is a nice structured strategy to get to the right answer? And I know that when it comes to dedicated study and preparing for Step 1 or Step 2, it is not just a content or strategy grind, but it's a mental grind as well. And I hope right now my energy is going across to you in your study space, and you are staying active and engaged and super positive as we go through this webinar today. Medicine is full of triads, and I'll say my triad when it comes to USMLE preparation is integration, clinical reasoning, having a peak test-taking psychology, and also being efficient. One of the videos that is on my YouTube channel that is very popular is how to take notes from UWorld. These are not necessarily content videos, but they are going to teach you skills so that then you can package content and have long-term memory of the highest yield material. Most importantly, and the count that we have is over 300 today, HyGuru is a family. It is a global community of lifelong learners in medicine preparing for the USMLE. This is just a snapshot of some of the students who have signed up for my USMLE Step 2 CK courses. I have same results for Step 1, but these courses have been designed to focus on the highest yield material. I'll tell you, the limitation of my courses, it doesn't cover everything, but if you end up getting a 80% hit rate on the top 100 concepts, I'm telling you, you are going to do so well on Step 1 and Step 2 CK. And that's my philosophy, is to be very high yield, to the point, vignette oriented, and make sure you think like the NBME test makers. This video is going to be part of my USMLE Step 2 CK playlist. I will say that this series of videos is very high yield, whether you're preparing for your shelf exams. And this topic today is going to be especially important if you are preparing for Step 1. I want to also let you know that this webinar today is a preview of my ethics webinar that I have integrated in both my Step 1 and Step 2 CK courses. I'm just going to drop the course links in the chat box right now. Feel free to check it out if you have not signed up already, but the ethics section is about 4 hours, and it is a part of my full content review that is in my Step 1 and Step 2 CK courses. I'll spend some time later on going through the step 1 and step 2 courses and answering any questions. But I first want to go into the crux of today's session and webinar, and that is going to be going through the healthcare systems-based practice, patient safety, quality improvement. When I was doing research for this video, I wanted to go through the step 1 and step 2 CK content outline. And as you can see, the social sciences, population health are going to be up to, for step 1, 10%, and for step 2, up to 10 to 15% of the exam. Now, when I was going through this, I was like, why did the USMLE start emphasizing this? Well, if you look at the timeline, in November of 2020, there was a USMLE bulletin that stated that there's going to be increased items in systems-based practice, patient safety, legal, and ethical issues. Along with that, in that same year, the step 2 CS was discontinued, and also step 1 moved to pass-fail. So now, in order to test communication, views on healthcare systems, practices, etc., there are going to be increased amounts of questions surrounding these topics that we'll be covering in this video. A lot of the time, students come up to me and say, hey, Rahul, isn't this like common sense stuff? And while I will say that some of the ethical principles as well as patient safety concepts are going to be straightforward, I would encourage you to think about this as a certain series of concepts that you'll need to recognize and apply. So I wouldn't necessarily go with the answer that, quote, just sounds right. I would root it in, for example, an ethical principle or in a public health concept before you put the right answer. And my hope today is I give you a few vignettes that give you some key definitions as well as vignettes so that we can apply our knowledge surrounding these topics. What I will tell you is that I like to start out with some test taking strategies. Why I put my picture here is that these are Rahul-isms. This is what I think are great ways for you to think about these patient safety, quality improvement, and public health concepts. So let's go through this. Whenever you're encountering a question like this, apart from thinking about it like a vocabulary glossary or dictionary, you want to always pick the answer that is going to focus on improving the system, not blaming a certain individual. You also want to be very patient safety oriented and patient outcome oriented. No matter what, the system is here, and you as physicians are here to help make the patient and their support system at the center of your care. This is especially true when you have a USMLE scenario of an impaired clinician. For example, let's say a colleague is going to have alcohol on his breath. Well, because you are so patient safety forward, even though that may hurt your professional rapport, you have the duty to report that, and you have to make sure that that impaired clinician does not harm the patient. Additionally, when it comes to test-taking strategies surrounding these types of questions, you want to maintain confidentiality. This is going to be anywhere from the elevator all the way to talking to other family members of the patient. You are going to give the minimum necessary information in order to drive the care forward. And one of the core components of a patient-physician relationship is the ability to maintain confidentiality. Sometimes confidentiality, especially in my field, pediatrics, has to be breached, especially if the patient is going to be an active threat to themselves or to others. Then you do need to escalate and maybe breach confidentiality. But in general, because we are focused on patient-centered care, you want to make sure that you are going to communicate only the need-know information to any ancillary support staff or family members. Another thing that I will say is that usually the correct answer is going to be anything that surrounds checklists, huddles, debriefs. RCAs stand for root cause analyses, figuring out what is the core issue or core problem. These are all really good framings to keep in mind because medicine is a team sport. So anything that says engage in a multidisciplinary discussion or hold a conference in which a protocol is developed usually is going to be the correct answer. Additionally, what I will say is if you look at these types of questions from a systems-based standpoint rather than an individual standpoint, you will recognize that to err is human. And this was a very popular book that relates to these USMLE concepts. And why is that? Because it basically says that we all show up in healthcare to take care of patients with really good intentions. And To Err as Human is a book that says that good people are sometimes in very bad systems. And the goal is to improve the systems because, in general, people who are going to be in healthcare are going to be good, though they are subject to biases sometimes. And as clinicians, in order for us to be really good, we need to be aware of the cognitive biases. The other thing that I will say is that you must think about the value equation when it comes to patient-centered care, which is quality divided by cost. What does that mean? So value is going to be what you are delivering to the patient at what cost. And cost doesn't have to just be financial. It could be time, resources, personnel. And so when you are thinking of developing protocols or putting the right answer, make sure that it also is going to be a high value decision. The first topic that we are going to be going through is related to cognitive error. Go ahead and type into the chat. In terms of cognitive error, which error is going to be where you are just looking at one data point and that is your diagnosis? Do you guys know what would be that cognitive error where you're just looking at one data point? Yeah, exactly. So basically with these cognitive error questions, guys, it is going to be a vocab game. They're going to give you a scenario and you have to figure out what is the vocabulary word. So the first definition that we have to go through is anchoring. And I kind of did like a sketchy-esque way in which I gave a little bit of a like icon to help you remember it. And that is with anchoring, you are fixing on initial impressions. You look at one data point, and that one data point is going to be the surrogate of everything related to your diagnoses. We're going to go through some examples, but remember, anchoring on one data point without revisiting other ones. Confirmation, you can think of this as tunnel vision. And that is emphasizing evidence that supports a presumed diagnosis. So you have tunnel vision to say that this is just one data point that is going to support my presumed diagnosis. Tunnel vision is going to be confirmation bias. And I will tell you, confirmation bias and anchoring bias go hand in hand. Now, availability bias is going to be where you are allowing recently seen conditions to sway your diagnosis. An example of this is going to be when I am in bronchiolitis season and I see a child who comes in with increased work of breathing. I'll say, oh yeah, I've seen it, it's bronchiolitis season. Availability bias says, I'm just going to sign that off as bronchiolitis. And I might miss other diagnoses like pleural effusion, pneumonia, etc., because the things that are most recent are the things that you may think are the most likely. And that is, again, availability bias. Availability relates to the recent events. And then finally, you have framing bias. Now, framing bias is the way that the material is going to be framed to you. And so this is where you are allowing patient context to sway your diagnostic approach. In handoff, if somebody is going to frame a patient in a certain way, you are going to then think of that diagnosis and that patient in a maybe biased way. And as a result, you are going to sway your approach. Let's go ahead and go through examples because this will drive these definitions home. So let's say that you have a middle-aged man with burning throat pain who now presents with weight loss. The resident continues to say it's GERD, because of the burning throat pain. Well, this is an example of confirmation bias. When it comes to confirmation bias, you got to think about tunnel vision. You have all the data points in front of you, and you are going to just tunnel vision into one element of the history, for example. Now, anchoring bias is a little bit different. The way you can think about anchoring bias is that if you see new information that is presented and the person is neglecting, the doctor is neglecting that new information, they are anchoring on old material. So let's go through this concept. 26-year-old male presents with chest pain and EKG changes showing diffuse ST segment elevations. He has pleuritic chest pain. Despite normal troponins, no atherosclerotic risk factors, so you got new information, the troponins were normal, you still told the patient to go for a percutaneous coronary intervention for a myocardial infarction. In anchoring bias, you neglect new information and you anchor on the old information and come up with a faulty decision. Now, framing bias is going to be how the patient is presented to you. For example, if you had a vignette in which the patient has sickle cell, and now you are not giving pain medication because the patient is from a low socioeconomic status and drug-seeking history, you have now framed that situation to sway the way you are taking care of the patient. Availability bias is going to be the recency bias, the fact that, oh, I just saw this. Let me go ahead and look at this diagnosis with just the fact that I saw it yesterday. So for example, dyspnea diagnosed as influenza as it is October. Because it's October, you're like, oh yeah, it's October. I've seen a lot of flu. This dyspnea is going to be flu. What about this one? If the dyspnea is there and you missed a CT showing a filling defect in a main pulmonary artery, you may have missed a pulmonary embolism because you were just so focused with the availability bias that anything that walks in the door with dyspnea is going to be influenza. So what I would say is for you to know the definitions, know examples, because these definitions are going to be best applied whenever you have an example to root the concept in. Confirmation bias, tunnel vision; anchoring bias, neglecting new information; framing bias, the way that material is presented to you; and availability bias, what you saw recently as a way to sway your current decisions. What I am going to do is compare and contrast premature closure and anchoring bias. I want to just take one step back and let you know that the USMLE is going to make things relatively obvious for you when it comes to these scenarios. They can't necessarily give you gray zone scenarios with gray zone answer choices. So I want you to lean in with a little bit of confidence when it comes to some of these terms that have overlap. And even UWorld states that, hey, confirmation bias, anchoring bias, they have a little bit of overlap. So just be confident in the sense that UWorld will give you a very objective, and even the USMLE will give you an objective scenario. So premature closure is a unique type of bias in which you are jumping to a conclusion without all labs actually even coming back. An example here is diagnosing a headache without considering other potential causes. When you're premature closing, you are saying that I know this already. I don't need other things to come back. I'm just going to say that this is the diagnosis. Anchoring bias is going to be over relying on the first piece of information without exploring new information. Anchoring bias, the example here on the USMLE is, let's say that you have a patient who presents with a thunderclap headache. The CT scan is negative. So me as a doctor, if I was anchoring, I'd be like, oh, CT scan is negative. It can't be subarachnoid hemorrhage. But now new data is coming in. Lumbar puncture, notable for xanthochromia. The patient maybe has a little bit of nuchal rigidity without fever, still, again, pointing to subarachnoid hemorrhage. But because I was anchoring on the initial CT, even though new stuff is hitting my face, I am just neglecting the fact that it could be a subarachnoid hemorrhage. So the physician says CT scan is normal. It can't be a subarachnoid hemorrhage, but there are other data points that are suggesting it. One other term that I want to give here is going to be diagnostic momentum. Diagnostic momentum, if you want to write down, is a term in which a diagnosis is not revisited. A classic example of this is when a patient, for example, has red leg, and that red leg from the ER is diagnosed as cellulitis, and they're admitted for cellulitis, and the admitting inpatient team just says, oh, the ER said it was cellulitis, so we're going to call it cellulitis. And that is another term in which the diagnosis is carried across settings without revisiting the data points. So that's diagnostic momentum. Think of ER to the floor, just keeping the same diagnosis. I'm going to transition and talk a little bit about the different types of error. Before I go into this, is everybody enjoying this webinar so far? Everybody good? Yeah? Okay, I have some fireworks here, and I appreciate everybody's reactions. Again, the goal here is to cut out any distractions and stay active and engaged, locked in with me. This is super fun for me, and I hope it is for you as well. Let's go through this. When we're thinking about different types of errors, I want to talk about certain events that can occur in healthcare. Let's say that you have a patient in which the penicillin allergy is listed. The patient gets penicillin and dies of anaphylaxis. This is a harm to the patient that occurs, but could have been avoidable. There could have been an EMR alert that says, hey, allergic to penicillin, even though on the side panel it says, hey, allergic to penicillin. This is going to be known as a preventable adverse event. A preventable adverse event, you know something about a patient like an allergy, the patient accidentally gets it and ends up having an adverse event. This is different than a non-preventable adverse event. A non-preventable adverse event is when a patient with no known penicillin allergy gets penicillin and develops anaphylaxis. This is where harm occurs despite appropriate care. The one that is frequently tested that I'm going to put a star on is a never event. A never event is going to be related to a sentinel event. This is such a serious event that it should never happen. For example, wrong site, knee, arthroplasty, or amputation. If you were supposed to operate on the right side and somehow, some way, the patient ended up getting their left leg amputated, that should be a never event. Another never event, closing up the patient in surgery with a retained foreign body. Now, one of the things that they will test you on is, okay, we have a sentinel event. That's a part A question. You need to know that sentinel events are going to be serious medical harm that should never happen. And the part B question they'll ask you is, so what do we do? And answers are going to be create protocols, safeguards, more communication, huddles, checklists. These are, again, systems level interventions. That's the take-home message for today. How about this one? An error that was intercepted. For example, an elderly female with no diabetes gets insulin delivered to the bedside, but the nurse doesn't administer. Do you guys know what that is? Go ahead and type that into the chat. Excellent. This is going to be known as a near miss. This is where a bedside provider is going to be able to catch a harm before it reaches the patient. So usually the patient is totally fine, but what was getting delivered to the patient was going to cause harm. And I will tell you that it is important for you to talk about near misses. Even though the patient didn't get any harm, you need to talk about near misses. And we actually start our safety calls in the hospital with identifying near misses. And we kind of celebrate the team and this person who is going to be catching that near miss. And it's very important because sometimes near misses that are truly going to be missed can lead to sentinel events. So this is going to be a model known as the Swiss cheese model. And the Swiss cheese model basically says that this is the negative outcome, the harm that was to the patient. And whenever there was a harm to the patient, there were multiple stages within the process in which the hazard, like insulin, ended up getting through the EMR, through pharmacy, through nursing, etc., to the patient. All of the holes lined up together. So in the Swiss cheese model, when you are thinking of improving the system, multiple layers of safety can actually prevent harm. And what that basically means is that there are going to be different double checks that you're going to put such that the cheese and the holes of the cheese do not line up. So improvement processes such as double blood verification or making sure that there is a huddle to check the exact concentration of the total parental nutrition or TPN. These are all really good safeguards that are going to align the cheese so that then you are not going to have a negative outcome. We're going to transition and talk a little bit about active and latent error. When it comes to active and latent error, you need to go through these vignettes and definitions. Let's go. Active error is a frontline error. Think of this right at the bedside. An example is look-alike medications or look-alike patient names. Whenever they say look-alike and there was some error that occurred, usually that is an active error. Contrast that with the latent error. A latent error is more of a systems-based error. A good example of this would be that the pharmacy has normal saline bags and lethal potassium chloride bags in the same shelf with similar labels. Now, that is a systems issue in which you are having two medications that look the same right next to each other. So an active error is more frontline error at the bedside, whereas a latent error is going to be more systems level hazard. In order for us to apply these terms and definitions effectively, I went through and created a few USMLE style vignettes. Let's go through a rapid review. Let's say that you have an immigrant patient with limited English proficiency is discharged after a myocardial infarction and now presents with recurrent chest pain after failing to understand antiplatelet therapy. So in this case, the factor that contributed the most to the patient's harm is actually going to be low health literacy plus or minus a language barrier. This is very important because now what you can interlay in terms of systems level change is that we have to educate each other and we have to educate the patient. And if there is a language barrier, you need to have a medically licensed translator to talk about the medications, for example, that the patient needs for discharge. The correct answer on NBME is not going to be have the brother who speaks the native tongue translate for the patient. The goal is to have a third-party objective person translating so that then things are going to stay very objective and there's not going to be a game of telephone or mixed messages or signals. Let's go through this next one. A single mother misses follow-up appointments for hypertension and now presents with a stroke due to inability to arrange for childcare or transportation. What factor contributed? Well, this is going to be socioeconomic barriers. This is very important because the correct answer on the USMLE may be address the barriers to getting care. This is all under the auspices of social determinants of health. Why at times patients can't access the healthcare system. And one of the next best steps in management is to consult social work because they can help the patient with limited resources or some barriers navigate the healthcare system. An intern on 20-hour call shift is managing multiple admissions overnight and now presents with wrong heparin dosing for a patient. What factor contributed the most to this error? Again, if you're watching this at another time, pause the video because active recall is so important. And this is going to be cognitive overload or fatigue. Anytime they're talking about many bells and whistles that are in front of you, as well as long hours, you have to be thinking of cognitive overload and fatigue. I'll tell you that this is why the education system, specifically ACGME, has moved towards limiting or having duty hours restrictions because there was increasing data to suggest that, hey, this might be contributing to a lot of fatigue for the trainees. Additionally, cognitive overload could be in a USMLE question where they say a new electronic medical record is instilled in a hospital. Every time the patient is, or excuse me, every time the physician is going to click in the EMR, there's a pop-up that comes up. That is an example of cognitive overload in which every time something happens in the EMR, a pop-up comes up. And sometimes what can happen is you can get what we call alert fatigue. And alert fatigue is this concept that, all right, I'm just going to keep clicking XXX. I'm not going to read the alerts that are there because there are way too many. Another example of cognitive overload is what I do in my day job. I'm a pediatric ICU doctor. So when there are a lot of people in the room, the child is decompensating, there's a monitor, there's a lot of yelling, there's a screaming, there's going to be different monitors. One monitor is not working. That's a high cognitive load. So your goal in healthcare is to make sure you work as a team so that then we can all share the cognitive load. All right, here we go. A resident, is convinced that a patient's chest pain is just, quote, reflux because it happens after meals, despite getting new data that there was an abnormal EKG and an MI is found. What is the likely error here? And if you are saying that this is going to be a cognitive bias known as anchoring, you're absolutely correct. So in the history, without revisiting any other labs, the patient ended up getting an MI, but the resident only latched onto one element of the history. Let's go ahead and transition and talk about the next rapid review vignette. A patient with atrial fibrillation is discharged without warfarin after admission and now presents with a stroke 1 week later. What may have prevented this error? So this is a really important point, and that is to do a medical reconciliation. This is called an omission error. So a patient has all the access and means to get the medication, but nobody at the end of the visit said, these are the new medications you need to take. So whenever there's an answer on doing a medical reconciliation, that's super important, where you're confirming these are the old medications, these are the new medications, what medications need to be continued if they are admitted. This omission error is when a med reconciliation is not done. Let's go through the difference between omission and commission. A commission error is cover your ass medicine. What does that mean? And I pardon my French. It's just in case. Oh, I have a viral upper respiratory tract infection. Oh, just here's some antibiotics just in case. So whenever you give a therapy, quote, just in case, that is going to be a commission error. And what does a USMLE like for you to know is that if you do too many errors of commission, opting into things that are not needed, you will increase healthcare costs, i.e., you will cause more waste in the system. And we're going to talk about that with value-based care. All right, here we go. A patient with a deep vein thrombosis prescribed heparin 5.0 units. There is now, quote, massive bleeding. The morbidity and mortality case presentation noted that the pharmacy hand wrote the heparin dosing, and it looked like 50 rather than 5.0. So what is going to be the likely error here? That is going to be trailing 0 that was misread, i.e., rather than 5.0, it was 50. So sometimes this administration error can be prevented by this. Look. So sometimes the correct answer will be write out the name or the amount rather than just the decimal point. Let's go ahead and go through this vignette. I want you all to answer in the chat box. What do you think is the correct answer? I'll read it out loud and then go ahead and put your answer into the chat box. A 67-year-old man undergoes a lap chole. During transfer from the operating table to the recovery bed, his endotracheal tube becomes dislodged, leading to severe hypoxemia and cardiac arrest. Resuscitation is unsuccessful. The hospital initiates a process to retrospectively review the sequence of events, identify why the error occurred, and implement system-wide changes to prevent recurrence. Which of the following is the most appropriate process to achieve this goal? Failure, mode, and effect analysis, incident reporting, mortality and morbidity conference presentation, root cause analysis, or quality assurance audit? What do you think is the best answer here? Excellent. If you are saying root cause analysis, you are absolutely correct. This is where a near miss or a sentinel event occurs and the team comes together in a multidisciplinary fashion to understand why the error occurred, and let's create a systems-wide change. One of the outputs of a root cause analysis is a fishbone diagram. This is where you are taking a look at the different factors that may have caused the problem. And a fishbone diagram comes out of a root cause analysis. And it essentially identifies the key drivers which may have contributed to the error or problem. It is a visual way to understand the problem and the different elements that may have led to the harm happening. Another important question that comes up on NBME exams is this concept of sign out and communicating safely in an uninterrupted manner with different healthcare providers. One of the approaches that you will hear in both nursing as well as in medicine is going to be SBAR, situation, background, assessment, and recommendation. So let's go through this here. A night resident covering the ICU receives a confused sign out and misses critical antibiotics for septic shock. What type of communication approach may have helped? Well, during sign out, if you used SBAR, situation, this is a patient with septic shock on norepinephrine. Background, he was admitted with pneumonia and now is getting worse. Assessment, he remains febrile with WBC count that is trending up. Recommendation, if he is getting worse, I would like for you to broaden coverage with ciprofloxacin, adding double negative coverage in addition to the piperacillin tazobactam. Sometimes in severe septic shock, we do add 2 antibiotics that cover gram negatives. So in this case, the omission was there because there was not good sign out in an SBAR manner. So let's go through this here. Whenever you're thinking about questions surrounding sign out, you want to make sure that there is a structured approach and you reduce interruptions. You also, in any patient-related or medication-related situation, use closed-loop communication. And what is closed-loop communication? Well, when I'm running a code, I will say, give 10 mics per kilo of epinephrine. The nurse looks to me and says, Dr. Damania, 10 mics per kilo of epinephrine going to be administered. 10 mics per kilo of epinephrine administered. That's closed loop communication where you receive, you say a message, and then the receiver reflects that message back. Let's go through another question. a 55-year-old woman undergoes a skin biopsy for evaluation of a pigmented lesion. The next day, the pathology laboratory notifies the clinic that the biopsy specimen was never received. The physician determines that the specimen was lost during processing, and the procedure will now need to be repeated. The patient is scheduled to return to clinic tomorrow, but the specimen is lost. Oh no. Which of the following is the most appropriate statement for the physician to make to the patient? Go ahead and type into the chat, what do you think is the correct answer here? And this is exactly the point that I was going for. Whenever there is some sort of error, you must disclose the error. The USMLE really wants you to know this. Here's a part B question. Same scenario. I just made it part B question. You're going to have that on Prometric. The physician explains to the patient that the specimen was lost due to tracking in the laboratory system. The physician apologizes on behalf of the team and assures her that the repeat procedure will be done at no cost. Which of the following is the most appropriate additional statement to complete the disclosure? A, we will notify administrators now of this error and we will change our procedure so that it does not happen again. B, you should contact the hospital to request compensation. C, if the lab had been more careful, this would not have happened. D, this is very unusual and we will make sure you don't have to go through another biopsy. Or E, there's no need to worry since your health was not harmed by this event. What do you think is the best answer? Correct. If you are saying A, we will notify administrators now of this error and we will change our procedure so it does not happen again, that's the correct answer. Guys, when I am going through my USMLE courses and these webinars, I am extremely intentional about the learning points that I want to deliver to you because they are very high yield for the NBME and Prometric exam. In this case, the 2 points that these two questions illustrate, number one, be very transparent about the error. And number two, take the ownership and say, we are going to enact systems level change. We're not going to blame that one person. We are going to enact systems level change in order for us to not have the patient or any other patients go through that again. Very, very important. Let's go through the principle of disclosing a medical error. When we're thinking about disclosing a medical error, like we saw in the question, clearly describe the error. Express regret and apology. There's literature that suggests that if a physician is going to immediately recognize the error and apologize, they are less likely to undergo a malpractice lawsuit. You want to be very transparent with the patient. Why did the error occur? You want to also be very patient-centered. And you know what I do? I explain to the patient, what are the next steps that we're going to take moving forward? I give a little bit of perspective of the back, and then I say, hey, this is what we're going to do moving forward. And you definitely want to then end by outlining actions to prevent future occurrences. And again, systems level change is the buzzword that we are going for. So when it comes to error, the ethical principle that drives you being very transparent of an error is veracity. Veracity is truth-telling. Also, there is a model known as the 5 whys. You just keep asking, why did this occur? Why did this occur? For example, IT did not print out a wristband having the patient's allergy. Why did that occur? Oh, the printer was broken. The nurse didn't see the wristband. Why did that occur? Because it wasn't in her orientation packet, et cetera, et cetera. You just keep asking, why did these errors occur? And then you can get also to the root cause. So a lot of these concepts are jiving together. Again, please note that this is a vocabulary and an application. Sometimes on the USMLE, 2 answers are going to sound similar. And when you're down to 2, it is knowing the science and knowing the definitions and knowing the knowledge, the frameworks, the concepts that are going to make you choose the correct answer rather than going by vibes with a Z. All right, here we go. So as I have molded this webinar, what we are noting here is that, hey, an error occurred. Now we need a systems level change. We want to improve. And this is where the plan, do, study, act, or plan, do, study, adjust. It's the same kind of concept. It is a cyclical and iterative process for achieving improvements. Let's break down each one of them. Plan. This is going to be where a multidisciplinary team comes together. The buzzword here is multidisciplinary. Comes together and suggests, hey, what are we trying to achieve? And in the plan phase, there is a SMART goal that is set. A SMART goal stands for specific, measurable, and achievable goal that is going to be realistic and able to be measured and timely. There's a time base. So a very specific thing would be, I want to reduce same or wrong site error by 2% by the end of the year. Something like that, that is specific and measurable. And the key here is, how are we going to measure it? That's where a lot of these projects get stuck. Let's go through this. The do. The do is where you implement or pilot the intervention. Maybe there is a checklist that is going to occur to prevent that specific error, or to improve, there's a checklist that is going to be done. And then you study that intervention. You get feedback. You get feedback from constituents or stakeholders. For example, in the study phase, you will see, hey, how many people actually completed the checklist? If nobody completed the checklist, we need to identify barriers. Because when you identify barriers, you then, in the adjust phase, be like, oh my gosh, this checklist had like 50 different items. Let's make it just 5 questions, i.e. make the checklist more simple. And then you do one more cycle where your plan is now going to be a shorter checklist. And what is the do, study, act? And you just keep going round and round until you sometimes hit your target or come up with a conclusion. So the goal here is to do quality improvement in a structured cycle, which is plan, do, study, act. One way, in a visual manner, to see whether or not you are on track is to think about a run chart. So a run chart is going to be a way for us to visualize data based on a benchmark sample. So let's say that this is going to be a length of stay diagram, and this is going to be the current length of stay. And what you're noticing here is, if you are lower than the current gold standard, you have achieved your target. So a run chart over time looks at, relative to a gold standard benchmark, how is the intervention or the team performing? In this case, lower length of stay is actually a good thing. And so lower is better when you're looking at hours in terms of length of stay. You're getting patients out quicker. So a run chart is a visual representation of how a process changes over time, and any answer that is surrounding a benchmark and then trying to either be above or below that benchmark, that is going to be a very important thought process as you create a run chart. We're going to pivot and talk a little bit about value-based care. Now, when it comes to value-based care, we make value decisions, for example, when we go to the grocery store. How valuable, or what's the quality of something, and at what cost? And again, cost doesn't necessarily have to be related to a financial. It could be things like convenience. So whenever you're thinking about value-based care, it is quality divided by cost. High value is good outcomes at a reduced cost. So Let's go through a few of these definitions in implementation science. Overutilization. This is going to be tests or treatments that are not expected to benefit the patient. How do you combat this? The awareness of commission bias. Remember, the commission bias was the example of like, oh, just in case you have a pneumonia, I'm just going to give you antibiotics. I don't know. I just want to be safe. That can lead to overutilization. Patient-centered care, that's kind of the theme of this webinar, is where you are making sure that you are coordinating care for that patient in a systems-based manner, sharing the decision-making between patient and other caregivers, and then emphasizing that patients' outcomes are the center of your goals. There are two value-based care models. It's Lean and then Six Sigma. Lean involves cutting out overutilization. It is removing inefficiency in a workflow. I'll say at my hospital, one of the things that we started doing was creating a patient waiting area. So the situation that was occurring was that patients would be ready for discharge. However, their ride wouldn't be able to pick them up for a few hours, but we still needed beds for new admissions. So the lean mindset said, wait a second, let's go ahead and create a patient discharge waiting area so that then when people are ready to be picked up, they can come out of the hospital bed so that then that can be cleaned for another patient and they can be in this waiting area. So again, that's a lean mindset, removing any inefficiencies. And Six Sigma is a way for you to reduce variation. This is also seen when you're thinking of car companies like Toyota. It is near elimination of defects through statistically driven processes so that then you reduce waste and you reduce variation so that all hospital systems can work in tandem, or all community sites can work in tandem. The last few concepts that we're going to be covering surround prevention: primary, secondary, tertiary. Let's go ahead and go through this question. A medical student is participating in a health fair. The student is particularly interested in understanding prevention to optimize his patient's health. Which of the following best describes an example of primary prevention? A, lipid lowering therapy. B, counseling on smoking cessation. C, hemoglobin A1C monitoring. D, colonoscopy. Or E, reducing polypharmacy. What do you think is the best answer? Go ahead and pause the video. Think of the answer to yourself. Wonderful. If you are saying counseling on smoking cessation, you're absolutely correct. Remember that primary prevention is all about preventing disease onset. So anytime you're counseling on healthy diet and exercise, that's primary prevention. Now, secondary prevention is to screen to prevent symptoms. In secondary prevention, you are trying to prevent disease. And this is where your vaccines and screening guidelines all are under secondary prevention. Tertiary prevention is to prevent any morbidity. What that means is that you are trying to treat a disease. The patient is already there with the disease. And so things like preventing sequelae from that disease, like hemoglobin A1C monitoring or urine analysis for microscopic albuminuria, is going to be an example of tertiary prevention. Whereas quaternary prevention is going to be not doing anything unnecessary, i.e., preventing over medication. And so when you're thinking of the screening, primary prevention is going to make sure you are preventing the disease before it occurs. Secondary prevention is detecting the disease, and tertiary prevention is to reduce the morbidity. Let's go through this question. A 28-year-old female is diagnosed with gestational diabetes. The OBGYN provides recommendations to monitor her blood glucose checks throughout the week and log it in a diary. Which of the following disease prevention strategies is most likely employed in this patient? What do you think is the best answer here? Good. The patient already has the disease and you're monitoring to prevent complications of that disease, and that's tertiary prevention. Very good. Let's go through another topic that comes up on USMLE Step 2 CK in particular. That is LGBTQ health. Let's go through these 4 vignettes. A young adult engaging in multiple sexual encounters who now presents with urethral discharge and dysuria. This sounds like a STI. What is a likely risk factor here? Well, the risk factor is going to be lack of barrier protection. Remember, things like HPV, gonorrhea, chlamydia, barrier contraception is very effective. Let's go through this next one. An adolescent female presenting for contraception counseling who wishes to avoid pregnancy but is concerned about daily medication adherence. What is a likely treatment option for this patient then? This is going to be something that is more long-term. So a long-acting reversible contraception, such as an implant or a intrauterine device, IUD, is going to be important. Let's go through this question. A 25-year-old transgender woman presenting for routine primary care. What is the next best physician response while communicating? Now, any answer on the USMLE with LGBTQ that surrounds affirmative care with inclusive language, for example, having the physician ask, how would you like to be addressed? What are going to be your specific pronouns? Doing preventative care based on appropriate anatomy. If the female is going to be in front of you and she has female parts, you may be doing things such as a pap smear. Again, the goal before all of these screening or care interventions is to make sure that the patient is comfortable and you are going to have inclusive language with respecting their pronouns. Let's go through this one. A 15-year-old assigned female at birth who identifies as a male requests information about hormone therapy. Next best step here is going to do gender affirming counseling and consideration of hormone therapy if appropriate. They're not going to get too complex here. They just want you to recognize that this is a patient population that is increasingly being seen in the healthcare system, and that we must continue to remain patient-centered in taking care of the LGBTQ plus community. I'm going to do an integration surrounding vaccines. So far, is everybody doing okay? We only have 4 more concepts left and then we are complete. Is everybody doing all right? I'm seeing a lot of hearts. Thank you guys so much. Anushri, Ashley, Arub, Kyle, Rimsha. Continue to stay active and engaged with me. Let's go ahead and go into this USMLE vignette. It was fun making this presentation. All right. A 32-year-old man is diagnosed with HIV infection during routine screening. His CD4 count is 350. He has no significant medical history. He received a Tdap vaccine at diagnosis 3 years ago. Prior to moving, the patient's records noted IgG antibodies to hepatitis B surface antigen. The physician reviews his vaccination history and plans to update him today. So in this HIV positive patient, which vaccines need to be given? I'm going to just have you pause the video and pause this right now so you can think about it, write it out on your scratch paper. No need to put it in the chat box, but let's just take about 20 seconds and see which ones you would give. This is kind of like a checklist type question. All right, let's go through this. When we're thinking about hepatitis B, the patient already has immunity to hepatitis B. Remember that whenever you have antibodies to the surface antigen, it's either you've had a past infection or you have been vaccinated. The patient is a little bit outside of the range of the HPV vaccine. When it comes to live attenuated vaccines, the CD4 count is going to be greater than 200, so we should be good to give that one. Pneumococcal conjugate vaccine followed by PPSV23 polysaccharide 8 weeks later. This one is frequently tested on the NBME. And then finally, Tdap, the patient got it at diagnosis and within 5 to 10 years, so we should be good. So in this case, the best answer is going to be the live attenuated zoster vaccine. You can give live vaccines to HIV positive patients with a CD4 count greater than 200. That's a small detail that was in UWorld, so I made sure to mention it. And finally, make sure in high-risk populations, such as the HIV population, preventing pneumococcal is important. We're going to be transitioning and talking a little bit about health system sciences. With health system sciences, I have shed light on Medicare versus Medicaid. I also want to go through different payer models. This is in first aid for the USMLE Step 1. Let's go through this. The difference between Medicare and Medicaid is that Medicare is a national program. And what it does is it takes care of elderly patients. So I say care for the elderly greater than age 65. But if you have end-stage renal disease, and let's say you're a pediatric patient, they'll say like the patient has focal segmental glomerulosclerosis and is on dialysis. Medicare actually covers patients who have end-stage renal disease. Now, Medicaid is going to be a joint federal and state program. It is traditionally for low-income households. So the mnemonic I like to use is care for the elderly, aid low-income households. And it has at times broad coverage. Even patients on Medicaid can get benefits for personal care items. Let's say you're going to your local drugstore and you need deodorant. Sometimes Medicaid can cover that or give a stipend. Now, Medicare, which is again for the elderly primarily, has different parts, and the USMLE does test this at times. Part A covers anything inpatient, hospice-oriented, home healthcare oriented. Part B, you can think of this more so as outpatient, short stays, such as in a hospital observation unit. It also covers preventative care. And Part D, D for Part D and D for drugs. Part D of Medicare covers prescription drugs and other medications. So this is important for you to keep in mind. Again, these types of questions are sneaking up, and that's why I wanted to include it. What is unique is that some patients may qualify for both Medicaid and Medicare, and that's called dual eligibility. In terms of healthcare payment models, there are certain definitions. When you're thinking about a health organization receiving a set amount per service, that is going to be known as a bundled payment. For example, you get X amount of dollars for appendicitis. How about this one? A set amount per patient assigned to them per period of time. So per patient, if you get a set amount, that's called per capita, capitation-based payment. Capitation means head, and so per head, you get this much. All right, how about this one? Patient pays for service at a discounted rate determined by the insurance company and the provider. That is going to be known as discounted fee for service. And then finally, patient pays for each individual service. This is sometimes for like cosmetic procedures or elective procedures. That's called fee for service. I want you to be very familiar with these terms. Again, the USMLE is going to make these terms in an applied scenario, and they are going to make them very obvious So please don't stress out too much. The USMLE definitely stays away from the political climate. They just want to certify brilliant, brilliant physicians like yourself. So that's the summary for today. Let's go through it. The test taking strategies still hold true. We talked about pick the answer that is related to the system, that focuses on the patient, does not blame a certain individual. Patient safety comes first. Report impaired clinicians. Make sure you maintain confidentiality, and anything that highlights that medicine is a team sport. I'm a pediatric ICU doctor. It is imperative for me to have a great team, and I'm grateful to have a great team. And when we have a team-based approach with good checklists, huddles, debriefs, good root cause analyses when error occurs, being transparent about errors, these are all going to be very important. And my hope is that you get these questions right on the USMLE. I just want to thank you all for joining. Again, remember that this is a free preview to my ethics 4-hour review that I have instilled in both my Step 1 and Step 2 CK course. I go through things in the ethics section related to different ethical principles, autonomy, beneficence, non-maleficence, justice, things like informed consent. And with that, I would like to transition to a little bit of question and answer session. If you do have to leave, I would encourage you to just spend 5 minutes going through a little bit about what the Step 1 and Step 2 CK courses are all about. This is a labor of love. Literally, I have continued to make videos little by little by little in order for me to be very relevant and up to date with the USMLE and what is tested on these NBME exams, etc. That's why, can you believe it? On the Step 2 course, I've put chart-based questions. I've written them and have put them in a test-taking strategy on how do you tackle chart-based questions. I've also, underneath my Step 1 and Step 2 videos, I have put not just any flashcards, vignette-based flashcards. I'm not going to do no close deletion type of minutia. Hey, a patient presents like this on the USMLE. What's the likely mechanism? It's a 2-step thinking question. And on the back, you not only are going to get a basic science tie-in, but you are going to get a little bit of a test-taking tip. So I hope you enjoy that in the course. Feel free to follow me at HyGuru Prep on Instagram, TikTok, YouTube, etc. I will tell you that if you have stuck around for the end of this webinar, I would encourage you to, number one, please place a review. And here is the review link. What did you like about the HyGuru methodology? And for you all being here today with your time and attention, I have created a Notion template, which is a unique software that helps you take good notes. Here's the Notion template that I use for both Step 1 and Step 2 CK. I've linked it here. You can go ahead and duplicate it in your Notion account. Notion is free, so this is a free template. And my hope is that you look at the different tutorials that I've placed in there, and you can effectively package all of the wonderful, wonderful content that is in these question banks. So with that, please check out my courses. If you have any questions, I will stick around for them. I have also in the Step 2 course injected a beautiful virtual question bank where I break down every question thinking like the test maker. And with that, I see some questions in the chat box, but thank you so much for joining me today. Before you leave, it's all about active recall. Type in one thing you learned, and I will go ahead and go through any questions. Thank you all so much for joining. One thing that you learned before you leave, and we'll get into the Q&A just for the next 5-10 minutes. All right? Appreciate it. This is awesome.